On behalf of the American Heart Association, I would like to welcome you to today's Implementation Science webinar, Lp(a) in Women's Health, the Missing Piece in Residual Cardiovascular Risk.
Good morning, everyone. I'm Dr. Stephanie Saucier. I'm the co-director of our Women's Heart Wellness program here at Hartford Healthcare's Heart and Vascular Institute in Hartford, Connecticut. I'm also a board-certified lipidologist and a non-invasive cardiologist. And I have with me an incredible doctor, Dr. Hilary Wagner. We are going to be talking to you all today about Lp(a), which is something near and dear to my heart. And so I just want to start by giving a disclaimer slide that the recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement for instruction by the Heart Association. The American Heart Association does not endorse any product or device. Just a little bit of housekeeping. All of the attendees are muted. Only the panelists will be on camera, so we will be on camera. The closed captions are available and can be engaged by clicking on the CC icon at the bottom of your screen. The session is being recorded and will be shared afterwards. Use the Q&A panel for questions anytime. If you are experiencing any technical issues, try leaving and rejoining the webinar or checking your internet connection. Stay until the end for our live Q&A. The resources icon located at the bottom of your screen looks like 3 pieces of paper. Choose Documents and click on the arrow to download the resource. And you can also connect with the American Heart Association team at the link below, which is www.heart.org/Lp(a) discovery. So,
Thank you, Dr. Saucier.
of course.
Before we get started, we'll just talk a little bit about Lp(a). High Lp(a) levels are genetically inherited and are a common independent risk factor for heart disease, affecting approximately 1 in 5 people worldwide. The 2026 ACC/AHA Dyslipidemia Guideline recommends that every adult have Lp(a) measured at least once in a lifetime. The American Heart Association launched a 3-year initiative, the Lp(a) Discovery Project, to increase Lp(a) testing by improving processes across care settings through national education. As an enhancement to this work, the association launched the Lp(a) CHC Discovery Project, which seeks to identify various approaches and barriers to Lp(a) testing within CHCs and develop national education to improve knowledge and increase awareness surrounding Lp(a). All right, it is my pleasure to introduce our first Lp(a) expert, Dr. Stephanie Saucier. Dr. Saucier is a non-invasive cardiologist and co-director of the Women's Heart Wellness program at Hartford Healthcare's Heart and Vascular Institute, as well as a medical director of Hartford Region Cardiac Rehabilitation Program. She is also an assistant professor at the University of Connecticut School of Medicine. Dr. Saucier earned her BS from Quinnipiac University and her MD from Ross University School of Medicine, and completed her internal medicine residency and cardiology fellowship at the University of Connecticut. Thank you, Dr. Saucier.
Thank you so much, Kelly. And again, so great to be with all of you this morning. So a few disclosures. I am on the Speakers Bureau for Amgen, Novartis, Arrowhead, and Cardamist. So today we're going to be talking about why Lp(a) matters. What is it? Why it's different? We'll specifically talk about Lp(a) in women and the sex-specific data. We'll talk about who to test, what to do, and what your role is. Then we will transition to Dr. Wagner, who's going to be going over some case-based learning, and then we'll transition to a Q&A session. So why does Lp(a) matter? Well, as you already kind of heard in the introduction, it's genetically determined. It's present from birth and is not captured by a standard lipid panel. Approximately 20% of the global population has an elevated Lp(a), and unfortunately, most people have never been tested. And so we want that to change, right? With the new 2026 lipid guidelines, we recommend testing every person at least once in their lifetime for elevated Lp(a). Community health providers are uniquely positioned to identify these patients who are at risk and to very early modify their risk and get them on appropriate treatment so that we can hopefully, recognize and mitigate the Lp(a) risk. So let's talk a little bit about the basics. Well, Lp(a) contains an LDL-like particle that's composed of an apolipoprotein B100, phospholipid, cholesterol esters, and triglycerides. There's also a unique apolipoprotein A that is linked by a single disulfide bond to the ApoB100. And so the way that I explain it to my patients often is it looks similar to an LDL particle, but it has this very sticky tail on it, okay? And so that's one of the ways that I typically explain it to people when we're talking about Lp(a). And so what we know is that lipoprotein A is pro-atherogenic, pro-thrombotic, and pro-inflammatory. And so what we see with patients who have elevated lipoprotein A is we see atherosclerosis, we see thrombosis, and we also see aortic valve calcification. Okay, and so there's a lot of variability with the Lp(a) concentration. So there's genetics, there's ethnicity and race, there's medical conditions, and then there's also environment. And so it's important that we recognize what the risk factors are from patients who have elevated lipoprotein A. And so lipoprotein A is an independent and causal risk factor for atherosclerotic cardiovascular disease. And in the absence of an acute illness, the Lp(a) is stable throughout an individual's lifetime and really mostly unaffected by lifestyle. And so we say that typically 90% of Lp(a) concentration is explained by an autosomal dominant pattern of inheritance and is fully expressed by 1 to 2 years of age. It reaches its adult level by roughly 5 years of age. So as I mentioned prior, Lp(a) promotes atherosclerosis and thrombosis, and the similarity of the ApoA to the proenzyme plasminogen increases the potential of lipoprotein A to compete with plasminogen for fibrin binding and decrease fibrinolysis. And so essentially, Lp(a) can increase plasminogen activator inhibitor 1 secretion from the vascular endothelial cells, block tissue factor pathway inhibitor, and promote platelet aggregation, all which contribute to increased clot formation, so that prothrombosis. And Lp(a) is the preferential carrier of oxidized phospholipids in the plasma that mediate a variety of pro-inflammatory responses in vascular cells. So when we're talking about lipoprotein A and what is high, very high, and when should we be talking about this? Well, we know that we want to measure lipoprotein A in nanomoles per liter for the most part. So it's very important to look at what your lab is measuring, if they're measuring in milligrams per deciliter or nanomoles per liter. But what we know is that elevated lipoprotein A greater than 125 nanomoles per liter creates a 40% increased ASCVD risk. Patients who have very high Lp(a) greater than 250 nanomoles per liter create a 2-time increased ASCVD risk. And so again, there's a pearl when we talk about the measurement. Units matter. So it matters if you're looking at nanomoles per liter versus milligrams per deciliter. They are not directly interconvertible. So it's you can't say that one is equal to another. You really need to be addressing your lipoprotein A levels based on your units, okay? And so the isoform insensitive assays are preferred, which is the nanomoles per liter. So that's why we're going to speak in regards to that. But I will sometimes talk about studies that have milligrams per deciliter as their defining feature. So these are the cutoffs. Normal for a nanomoles per liter is less than 75. But again, between that 75 and 125, the greater than 125 is a high risk. So the lipoprotein A allele size has an inverse correlation between ApoA isoform size and the Lp(a) levels, okay? The median Lp(a) levels are higher among African and South Asian ancestry groups. And there are carriers, okay, who have fewer Kringle repeats that have higher Lp(a) concentrations and higher risk. So there's a lot of this that comes down to, again, the genetics of somebody, what their ancestry is, and what their genetics are. So when we talk about the association of Lp(a) variants with risk of coronary disease and the implications for Lp(a) lowering therapies, we know that Mendelian randomization analysis involving more than 80,000 patients and over 150,000 controls showed that the coronary artery disease risk was proportionally associated with the absolute change in plasma Lp(a) mass concentration. So 101.5 milligram per deciliter, again, this was milligram per deciliter change in Lp(a) was associated with the same coronary heart disease risk as a 38.67 milligram per deciliter change in LDL-C level. And so this illustrates why it's so important that we are managing, we're looking at Lp(a) and we're addressing risk. Lp(a) concentration must be lowered by approximately 100 milligrams per deciliter to achieve the same reduction in coronary heart disease risk as can be achieved by lowering LDL-C cholesterol by 38.67 milligrams per deciliter. So when we're managing lipid risk, LDL obviously is something that we are very in tune and very adept at lowering. And so when we're talking about Lp(a), we also, and in essence, end up talking about LDL as well. So let's dive into a little bit of Lp(a) in women, sex-specific data. So women have higher Lp(a) levels than men. And in the Women's Health Study, where 28,000 women over 30 years were followed, Lp(a) was seen as an independent predictor of major adverse cardiac events. And overall, there was an additive risk when combined with elevated high sensitivity of CRP and LDL-C. And as you can see on the right-hand side, this comes from the Women's Health Study. So you see the cardiovascular events in the top, and you see this cumulative risk, okay? And then you have coronary heart disease events and stroke events. And so again, you see that cumulatively, the patients who have higher Lp(a) have this additive risk when combined with other risk factors such as high sensitivity CRP or hyperlipidemia. We also know that Lp(a) can increase up to 27% after menopause, and Lp(a) can potentially double during pregnancy. We also know that hormone replacement therapy reduces Lp(a) on average about 17 to 23%. And we know that Black women have the highest median Lp(a) levels. And so why is that important? Well, it's important because when we talk about measuring Lp(a) only once in a lifetime, we may want to consider, and again, this is just more of a kind of opinion, is we may want to consider in some women after menopause, checking again, right? And also being cognizant if you are testing someone's Lp(a) during, and they happen to be pregnant, you may want to repeat that later on. Again, that's an opinion of mine from a practice standpoint. And so let's kind of prioritize into who to test, what to do, and what your role is as a provider who's potentially seeing these patients. Well, as we mentioned a couple times, the 2026 Lipid Guidelines recommend measuring and testing Lp(a) at least once in a lifetime for all adults. And ideally, that's with the first lipid panel. And so it's really important that we prioritize testing in family history of premature coronary disease, postmenopausal women, high prevalence racial and ethnic groups, and that if you find someone who has a high Lp(a), doing cascade testing. So you want to test the family members, first degree relatives. It's important that when you have first degree relatives that have high Lp(a), that you subsequently test everyone else. So whether it be a reverse cascade testing, testing parents, or general cascade testing where you test then siblings and children. But that is really important. So we want everyone to be tested at least once. Now, what to do? Well, right now, what we aim for is aggressive LDL-C lowering. And so in my practice, we practice to getting a goal LDL less than 70. And we should use Lp(a) as a risk enhancer. And this should tip the scale towards initiation of statin therapy. And so when you have someone who you're doing the prevent risk score on, you want to make sure that you're using your other risk enhancers, Lp(a) being one of them, to assess and personalize that patient's risk. So in the 2026 guidelines, we really elaborated on CPR, which is categorize, personalize, and then recategorize. And so that personalization is really important. So someone who has a strong family history and has a high Lp(a) might not score incredibly high or at risk from a prevent risk calculator score. But again, their other risk factors and their risk enhancers should gear you to wanting to be more aggressive. We know, and we want to remind patients that Lp(a) is predominantly genetic and it's not their fault. A lot of patients come to me and they say, well, I'm eating healthy and I'm exercising and I'm doing all of the right things. Why aren't my numbers changing significantly? Or what did I do wrong? And I think it's really important that we take that blame away from them, right? We take that blame and we put it somewhere else and we say, you know what, this is not something that you did wrong. This is predominantly inherited, but we're going to work together to modify your risk and to try to minimize your risk as time goes on. And so let's talk about some of the historical treatments, okay? So in the past, there were two medications, mifemerson and lomipitipib. Oh, goodness. Lomipitipib, excuse me. And basically, mifemerson was an antisense oligonucleotide against ApoB100. However, there was a severe hepatotoxicity, so this medication is not on the market. And the second one is a microsomal triglyceride transfer protein inhibitor and also had significant hepatotoxic effects. And so what about the things that we have now? Okay, so let's talk a little bit about drug therapy and how it affects risk in patients with atherosclerosis with Lp(a). And the reason why I say this is it's incredibly relevant clinically, right? So statins can minimally or mildly increase Lp(a), but rosuvastatin 20 reduced atherosclerotic disease, okay, equally in all ethnicities, whether someone's Lp(a) was above or below the median. And so again, this may be the tipping point for patients with high Lp(a) of saying, okay, we're going to treat, we're going to put someone on therapy. Ezetimibe has very minimal impact on Lp(a), and there's no known effect on ASCVD outcomes. The PCSK9 inhibitor, so evolocumab, had a decrease in Lp(a) by a median of 27%, and it reduces the relative risk of CHD death, MI, or urgent revascularization, 23% if the Lp(a) was greater than 37 nanomoles per liter versus those with an Lp(a) less than 37. And then aliricimab decreased Lp(a) by a median of 29%. And the proportion of MACE reduction was attributable to changes in Lp(a), greatest in those with Lp(a) greater than 59.6 milligrams per deciliter. And so these are some of the medications that we see and we use every day and kind of what their effect is. Now, there are a number of antisense oligonucleotide against Lp(a) and short interfering RNA therapies that are currently in clinical trials. And so this is basically a summary of some of those, okay? What they do is they target hepatic ApoA production. And so far in phase 2 clinical trials, they have demonstrated significant reductions in Lp(a). So we have a few molecules. Pelacarsen is an antisense oligonucleotide. It's a subcutaneous monthly injection. There was a max Lp(a) of 80%. And the results, the outcome data is expected in 2026. Olpasiran is an siRNA molecule. It's a subcutaneous injection every 12 weeks with a 98% max Lp(a) reduction. And again, expected results potentially in 2026. Lipodisiran is an siRNA molecule. That's a Q6-month injection, 98% max Lp(a) reduction, and expected results in 2029. And then we have zerlasiran, which is an siRNA molecule, and expected results are to be determined, as well as molvaplin, which is a small molecule inhibitor, okay? So a number of medications are currently in phase 2, phase 3 clinical trials, and we hope to see some of these results in the coming future. What we do have also currently is a lipid apheresis for Lp(a). And so we know that that's the most effective treatment available, only current FDA-approved treatment, okay? Lowers Lp(a) by 60 to 80%, and is associated with significant MACE reduction in individuals with progressive atherosclerotic disease. The Pro-A Life study is one of the main studies that showed this. And unfortunately, lipid apheresis is less accessible and it's more intrusive. The FDA approved use of apheresis in individuals with atherosclerotic disease who have an LDL of greater than 100 and an Lp(a) greater than 60 milligrams per deciliter. And so these are the patients that potentially could be great candidates for lipid apheresis. And so where does this come from? Well, we know that there was a prospective 5 years of follow-up in Apolipoprotein A characterization study. And so prospective observational multicenter study included 170 patients with Lp(a) and progressive disease. Apheresis was found to have a lasting effect on prevention of cardiovascular events in patients with high Lp(a). There's regular ongoing apheresis was associated with stabilization of progressive cardiovascular disease. And the annual incidence rates for MACE were 885 and 81% lower during chronic apheresis in comparison to the progressive phase of patients prior to starting apheresis. And so what we found was that Lp(a) concentration seemed to comprehensively reflect Lp(a) associated cardiovascular risk in this study. Now, antithrombotic treatment. So a lot of times, and as I mentioned before, Lp(a) can be prothrombotic. So we have that low dose aspirin is effective in lowering risk amongst patients with ASCVD, as well as primary prevention in the right patient population. There's a possible link to aspirin lowering Lp(a) through reduction of ApoA production in the hepatocyte cultures. And the ASPRE trial was a sub-study that showed patients with Lp(a) polymorphism had a 46% relative risk reduction for combined endpoint of MACE on aspirin. And patients with elevated Lp(a) benefit more from low-dose aspirin therapy than the general population for primary prevention. So although these days we don't recommend aspirin for all comers from a primary prevention standpoint, there is some evidence that patients with high Lp(a) benefit again from baby dose aspirin or low dose aspirin. And we really need additional randomized controlled studies, but this is some of the emerging data that's out there in aspirin therapy for patients with Lp(a). And so what's your role? Well, screening is number one. We want to get patients tested. And then advocacy, working on cascade testing, addressing disparities in testing access. Risk reduction and aggressive LDL treatment would be the next step. It might be that thing that puts you over in terms of, hey, I need to treat this patient for their cholesterol. And then also know when to refer to a lipid specialist. If you have a patient who is having progressive disease, you might need apheresis, you're getting into trouble with patients not tolerating medications, that's where we come in. That's where the lipid specialists and the lipid clinics really come into play. But number one is screening and then cascade testing, and ultimately using the knowledge that you gain to aggressively treat your patients. And so now I'm going to transition over to Dr. Wagner. So Dr. Wagner is a non-invasive cardiologist. She completed her cardiovascular fellowship as well as her internal medicine residency with the University of Connecticut. So we're incredibly proud to be partners with Dr. Wagner. And she's going to walk you through a few cases before we hop into our Q&A session. So Dr. Wagner.
Thank you very much. I'm going to be going over some cases to help hone in some of the teaching points that we went over. So the first case, I have no disclosures to discuss. The first case is a 38-year-old African-American female, BMI of 26. She's a non-smoker, no personal history of cardiovascular disease, but her mother had an MI at 52. She gets a lipid panel done. It shows an LDL of 118, an HDL of 58, triglycerides were 95, and her 10-year ASCVD risk comes out at 2.8%. So the question is, should her Lp(a) be checked? So current guidelines are that everyone gets an Lp(a) once in their lifetime. It's particularly important in anyone who has a history of premature ASCVD in their family, familial hypercholesterolemia, borderline or intermediate risk patients, and then also those with recurrent ASCVD, even on optimal LDL. So we're checking this because traditional risk factors typically underestimate the risk in patients with elevated Lp(a). So her Lp(a) comes back at 180 nanomoles per liter. Normal, we know, is less than 75. So this places her in the high category. And based on this, her management is going to change. So her LDL goal is going to become much more aggressive as this elevated Lp(a) is a risk enhancer for her. So we're going to consider statin therapy despite her low risk. Her target LDL typically would be less than 100, but for her, given her enhancing risk features, would probably be less than 70. And then we also really want to talk about some lifestyle counseling with her. We know that lifestyle doesn't have a meaningfully effect to lower Lp(a), but it does modify her risk overall. So we want to talk to her about exercise, blood pressure control, avoiding smoking, and weight management. And then finally, we want to talk to her about protecting those that are close to her. So cascade testing in all of her first degree relatives, so her parents or siblings and any children. So that brings us to our next case, which is a 56-year-old female who's 4 years postmenopausal. She's on atorvastatin 20 milligrams a day. Her LDL-C comes back at 72. Her Lp(a) was checked 10 years ago and was 95 at the time. And the patient says, my cholesterol's in the green. Do I still need to worry? So here, LDL-C of 72 really doesn't eliminate her risk. We know that elevated Lp(a) creates residual risk independent of her LDL, and she is in that intermediate risk or to high risk category. So the recommendation would be to check her Lp(a). And we do that, and it comes back higher now at 145. So why did her Lp(a) increase? We know that it's genetically fixed and should be measured once. However, menopause can increase levels and can cause it to rise in 15 to 25% after menopause due to significant hormonal changes and inflammatory changes. So in this case, we would recommend retesting. And so the patient then is very astute and asks, should I go on hormone replacement therapy to lower my Lp(a)? And hormone replacement therapy can reduce Lp(a) by 20 to 30%, but right now it is not used to lower Lp(a). Current guidelines don't recommend starting HRT for cardiovascular protection or Lp(a) lowering. So what should we do instead for her? It's all again about going over her risk factors and trying to mediate those. So optimize her LDL even further to less than 70, potentially less than 55. Optimize her blood pressure, weight management, and diabetes. And then we have our last case, which is a 63-year-old female. She had an MI at the age of 54. She has new angina again, which required a PCI. She's already on maximally tolerated statin and Zetia. Her LDL is 55 and her Lp(a) is very high at 310. Her LDL is at goal, but why is she still having these events? Well, Lp(a) consists of an LDL-like particle, ApoB100, and that apolipoprotein A. And the ApoA resembles plasminogen and promotes thrombosis, impaired fibrinolysis, and plaque inflammation. So she's very high risk, and this is likely the driver of her initial MI, recurrent events, and her progressive disease. So what do we do for her? Again, we're going to optimize her LDL even further. We're going to try, she's already on the high intensity statin and Zetia, but we could try adding a PCSK9 inhibitor for her because we know the benefits of PCSK9s. They can lower LDL-C by 50 to 60% and that Lp(a) by 20 to 30%. And those are from the Fourier trial and the Odyssey outcomes. So patients with higher Lp(a) derive the most benefits from these PCSK9 inhibitors. And then if that doesn't get her to goal, we can also go to the lipoprotein A apheresis. Generally, we've reserved for the patients with progressive ASCVD, very high Lp(a), and recurrent events despite maximum therapy. So I hoped that those cases helped highlight some of the important facts from the talk for some of our take-home points. So Lp(a) is common, it's genetically determined, and it's an independent risk factor for ASCVD. About 1 in 5 individuals will have elevated levels. We want to test every adult at least once, particularly important in those with history of premature ASCVD or those with family history. Remember that women have higher Lp(a) than men, and levels can rise after menopause, so you could consider repeat testing them after 50. And right now, there's no approved pharmacological approach to Lp(a)-specific therapy. The current strategy is just aggressive LDL lowering and risk factor modification. But in the future, there are new exciting drugs coming, and we're just waiting for the results of those studies. So there's hope. So thank you for listening, and we want to invite any questions that you would have for us today.
Thank you both for the insightful presentation and highlighting Lp(a) as a critical and often overlooked component of cardiovascular risk in women. I'm going to hand it over now to my colleague Jeremy, who will handle the Q&A session from here.
Thank you, Kelly. Hi, Dr. Saucier, Dr. Wagner. We have a couple of questions here, and so the first one is either of you can answer the question. So the first question is, should LPA be a part of a pediatric workup by the age of 5? Wouldn't this help preventative health care and solidify healthier lifestyles at younger ages?
That's a fantastic question. So, the new 2026 guidelines recommend initial lipid screening in non-familial hypercholesterolemia patients at age 9 to 12 years old. Okay, so my recommendation would be, yeah, why not test at that initial lipid screening at age between 9 and 12? Now, there's a bit of a caveat with that. In patients who have familial hypercholesterolemia, oftentimes we sometimes will test children even younger based on their parents' history and based on their parents, if they're homozygote familial hypercholesterolemia patients or not. But for kind of the general public and the general population, I think testing for Lp(a) during that initial lipid screening from ages 9 to 12 is very reasonable and would give you, not necessarily, you might not necessarily treat right away, but it would give you a good idea of what that risk is and really modifying risk factors, starting with lifestyle modifications young. We all should be making sure that our patients we're talking to, our kids and everyone about lifestyle, healthy eating, healthy exercise and activities, right? In an age appropriate way. I am not a pediatric cardiologist, so I will defer that to anyone who treats kids in the audience. But yes, I think that testing in that 9 to 12 year range is very reasonable.
Thank you so much. I just want to remind everyone that the chat is open for questions. So the second question here is, how can clinicians navigate insurance barriers, especially when some plans consider LPA testing experimental or investigational, to successfully obtain coverage or approval for the test?
So there's a few ways to do that. So if you're doing cascade testing, which means that someone has a family history of elevated lipoprotein A, you can very easily use the ICD-10 code of family history of Lp(a). So that's an easy one right off the bat. So if you do have someone who has strong family history, that's one of the codes I would use. The other code that I would use for Lp(a) screening is I would use, if someone had, again, family history of premature coronary disease, maybe without a diagnosed Lp(a), I would use family history of premature coronary artery disease. And now that the 2026 lipid guidelines say that every person should be tested at least once in a lifetime, I just put and typically in our practice, we put it under lipid screening. And then if the insurance companies have a concern, or if we get any pushback saying it's experimental, it's not experimental, and it's actually in our lipid guidelines. So I think the fact that the lipid guidelines have appropriately put Lp(a) screening in, I would send that if you ever get a kind of a note back from the insurer saying, hey, we're not going to cover this. What I would do personally is I would, pull out the page from the lipid guidelines where it says Lp(a) screening every person at least once in a lifetime, and I would submit that. And then if you do have a patient, so that's another way to do it. And then if you have a patient who has high Lp(a), we don't traditionally repeat testing if you don't have them on something that modifies their Lp(a). So if I have someone on a PCSK9 inhibitor, or if I have someone on an apheresis, I will trend their Lp(a). At that instance, you're going to use the code for elevated lipoprotein A, and then you shouldn't have any issues with coverage. So there's a lot of ways to make sure that the screening is covered, or testing is covered. And again, now with the new lipid guidelines, that should help us even more. Even though in the past we had the European Society of Cardiology, National Lipid Association had recommendations for testing once in a lifetime. So I used to, prior to March 2026, I used to use National Lipid Association documentation and the European Society guidelines to help get those covered.
Awesome. Thank you so much.
Of course.
All right, so I have another question here. Are there any cholesterol medications that women tend to tolerate better or worse than men in terms of side effects or other drug interactions?
So that's a fantastic question. I am not aware of any head-to-head trials between men and women. However, I will say that I think it's important to recognize, I think it's really important to just respect patients' opinions when they come in saying that they're having side effects, listening to them, addressing them. Some of the statin studies on statin-associated myalgias did not have a strong female population that were included, right? And so I think that it is important that we listen to that, we listen to our patients, and we respect them. What is really nice, though, is some of the medications, the non-statin medications, in their landmark clinical trials, there were, a large percentage of the population in them, or at least, 40 to 50% women included in some of those trials. For example, Vesalius had 43% women in their clinical trial most recently. And so I think there's been nothing head to head. We have some anecdotal kind of experience with men versus women. But again, I think the most important thing to do is recognize when your patient has a side effect or a symptom and what other medications they're on, just really personalizing their care. So I don't know, Dr. Wagner, if you have another insight into that, but that was my experience.
Yeah, I think just to echo what Dr. Saucier says, that if a patient is concerned that there's a side effect, I try to listen and then try to find an alternative medication that they're more comfortable with taking.
Sometimes it's trial and sometimes it really is trial and error.
All right. I have a few more questions that have come in.
Great.
All right. So the next one is, do you consider MASLD a risk enhancer? Do you have any specific LDL goals in mind for those with MASLD? And last part, considering an additional pro-inflammatory state, especially if concomitant LPA elevation. I don't know what that is. All right. I don't know the word. I apologize. CONCOMITANT.
So two kind of different questions. Yes, I do believe that MASLD is a risk factor. And so what we know, even in the non-alcoholic fatty liver disease patient population, is that modifying and making sure the lipids are low is going to be helpful. So in a lot of these patient population, first line are statin therapies to help protect those patients, because that is, when we look at the whole cardiorenal metabolic picture, fatty liver is also a risk factor for heart disease. And so, yes, I do think it's a risk factor for heart disease. And it is something that I take into consideration when I'm talking and individualizing care for my patients. And then the second question is, you know, when you have lipoprotein A and you have high inflammatory process, again, if we look at the risk enhancers that are in the guidelines, elevated high sensitivity CRP is a risk enhancer. And so if you have high Lp(a), high elevated high sensitivity CRP, these are features that are going to go above and beyond that prevent risk calculator and gear you or lead you to be more aggressive with lipid lowering to help prevent or modify risk. You're also going to want to do things that help, you know, decrease inflammation. You're going to want to, you know, statins have good inflammatory response. You want to have good, healthy lifestyle, exercise, not smoking, you know, controlling blood pressure, all of these things, right? All of life's essential 8 that we talk about kind of routinely. So to answer to the questions, yes, MASLD definitely is a risk enhancer, in my opinion, and I am pretty aggressive with those patients. And then on the flip side, inflammatory with the lipoprotein A concomitantly, absolutely, I would be more aggressive with their risk factor modification as a whole.
All right. So next question here, should hormone replacement therapy be used to lower LPA? And if not, why?
All right, so that is a great question. And, you know, hormone replacement therapy currently it's not recommended that we're using it as a blanket to treat Lp(a). Okay. Again, we do not have trials. We know that hormone replacement therapy lowers Lp(a), but we do not have any clinical observation, randomized, double-blind controlled trials saying that it is better than aggressive risk factor modification. So that's why it's currently not recommended. Now, if you have a patient who comes to you early in their menopause, perimenopausal time period, and they really want to try hormone replacement therapy, and you have a high Lp(a), I think trending it to see kind of where it goes is not a bad idea. And, you know, it would help me also say, yeah, you know, if you want to go on hormone replacement therapy, we can, you know, we support that at this point. There's a lot of nuance to hormone replacement therapy in terms of who the right person is, the risk, the benefits. And so I think it's really important, again, and I keep saying this, but to individualize care. You know, if you have someone who comes to you who has been since menopause for over 10 years and they want to go on hormone replacement therapy to lower the Lp(a), I don't think that's appropriate. You know, again, I don't have good clinical trials showing that using hormone replacement therapy solely for Lp(a) reduction actually has cardiovascular outcome data. I don't have that information yet.
All right, thank you. All right, so I have another question here. If someone has elevated LPA and a statin is started, will you trend the LPA after starting the statin?
I will not. So I won't tend to trend the Lp(a) after the statin is started. And the reason why is because, as I showed earlier, statins can sometimes minimally increase Lp(a), and I find that patients really cling on to that number. And I'm sure you've experienced this too, Dr. Wagner. They really like hold on to it. And so they're like, oh my goodness, my Lp(a) went from 175 to 180. And that's very anxiety provoking to them. So again, unless I'm using a medication that has been shown to lower Lp(a), so your PCSK9 inhibitors or LDL apheresis, I'm not trending Lp(a). And I tell the patients that right from the beginning. And the reason why is I think it's really important that we manage expectations around those lab values. I don't know if you had the same.
Yeah, it can go up minimally and it can be very disappointing to the patient, and then they might want to stop the medication or lower it, and that's really not an indication to do that at all. So I would not recheck it afterwards.
All right, thank you. So if you have to do a trend text analysis, retrospective observational study, what do you think are the medications to do a head-to-head comparison for elevated LPA in men versus women?
Oh, that's a great question. I mean, I think that I would look at PCSK9 inhibition. I would look at statins. I'd add in hormone replacement therapy, you know what I mean? But those would be the things I'd look at for now. Again, hopefully in the near future, we'll also have some Lp(a) centric drugs specifically looking at Lp(a). And so I'm also really curious to see the kind of subgroup analysis and comparison from men to women in those clinical trials as well. But I think if I were to create a trial, I would obviously look at the statins, look at the Lp(a), modification agents, both the monoclonal antibodies and the siRNA molecules. And I would love to put in something about, actual outcome in terms of hormone replacement therapy. But great question.
Okay. And I have one more here. Do you consider PGX testing as an additional measure to assess response to statin therapy?
By PGX testing, are you referring to lipoprotein particle size testing, or are you referring to a separate type of testing?
Pharmacoeconomics.
I am not aware of pharmacoeconomics testing in my experience. Sometimes we will get advanced lipid panels and look at particle sizes, Lp(a) to assess, but pharmacoeconomics testing, it's not something I'm very familiar with. So I'm going to have to do some education to myself.
Okay, well, that was the last question. I think I was pronouncing the word incorrectly. It seems like it's pharmacogenomics. Does that change your answer at all?
Oh yeah, so pharmacogenomics. So like the genomic testing, that there's a ton of really great potential studies going on in genetics right now. And so I think that it should be done in combination with standard testing, including lipid testing, Lp(a), high sensitivity CRP, ApoB. I think it should be done in combination with all of our standard testing. But I think that it helps with personalization of care as a whole. Now, the problem with that is not everyone reads it, interprets it the same. So one thing I do caution patients to just kind of blanket going out and getting some of these studies done and then not having or ordered by someone who actually can't interpret them. Here we have not started it yet, but we have a conversation ongoing with we also have a genetic specialist. And so we would want to do it in conjunction with our genetic team because we do think that there's incredible potential benefit to it, but it has to be done in the right hands for the right patient population. I don't think that it should be just done, like I said, it should not be ordered just widely without someone who actually knows how to interpret these labs and in a really succinct way. So I think that yes, there is benefit to it, but like I said, we're even still trying. And, we come from a practice of lipidologists and preventive cardiologists, and we still are finding how does that fit with our patient population. So stay tuned. Like I said, we're starting up a program, hopefully in combination with our genetic team.
All right. Well, that was all of our questions. I do want to apologize for mispronouncing some of the words. But yeah, I'll go ahead and pass it back to Kelly for the closing. Thank you so much, Dr. Saucier and Dr. Wagner.
Thank you.
Yes, thank you, Jeremy, also for taking that on. A very special thank you to Dr. Saucier and Dr. Wagner for your excellent discussion, and to our audience today also for your engagement. We do encourage you to explore our Lp(a) patient education resources at heart.org/Lp(a). There's the link there in the chat. When you exit the webinar, a brief feedback survey will appear in your browser. Your input is greatly appreciated, and it helps us tailor future Lp(a) education to your needs. Finally, today's session was recorded, and all registrants will receive an email with access to the recording in the coming weeks. Thank you again for attending today's webinar, and we hope to see you at our future Lp(a) discovery events. Have a great day.